My name is Lucas Mlinovich, and I have been given the opportunity to pinch hit for Aaron Levo, who cannot be with us today, unfortunately. So hopefully I carry the torch in his honor. Thank you all for taking some time out of your very busy day, very busy weeks, very busy schedule. Do appreciate your attention to the important issues going on across the organization. And with that, we'll start off by handing it over to our CEO, Rob McIsaac.
Yeah, thanks very much, Lucas. Good morning, everyone, and thanks for joining our town hall today. I'll begin with our land acknowledgement. We're privileged to provide care on lands that Indigenous peoples have called home for thousands of years. We recognize and respect the presence and stewardship of all Indigenous peoples as keepers of this land. Maybe I could note that flags at Hamilton Health Sciences are still at half staff in honor of the unmarked burial sites that have been discovered at residential schools across the country. And we do this in support of Indigenous patients, families, colleagues, and community members. McMaster Children's Hospital and Ron Joyce Children's Center are also continuing to be illuminated with orange lighting at night to mark this solemn happening. I would encourage all of you to visit the hub for resources and learning opportunities to support the ongoing effort to improve Indigenous care and services across every one of our sites. Thanks for your ongoing interest and engagement in this work. As you'll hear today from Sharon, work continues to return our services back to at least some semblance of normalcy. And I think we're making progress. More staff have returned to their home units, and we are seeing a diminution in the number of cases, COVID cases at Hamilton Health Sciences. Although we cannot let our guard down for a moment, and by no means can we declare the pandemic to be over. Nonetheless, planning for surgery resumption and post-COVID care continues locally, regionally, and at provincial tables, recognizing the diversity of healthcare needs that our population has. We recognize the pandemic had an impact on some of our transformation work at Hamilton Health Sciences, and definitely very grateful for all of those people who continued to provide leadership and kept initiatives moving forward, notwithstanding the great challenges and stresses that have been placed on our hospital. Project Odyssey is one of those transformational initiatives. Barry Lum is here today to provide a brief update, and you'll be hearing from him and the team more frequently in the months ahead as we come down to the go live date for our EPIC implementation. We'll also continue to share regular updates through our various communication challenges in the weeks ahead on this hugely important project. As I mentioned last week, or 2 weeks ago rather, we've begun slowing down the frequency of our town halls, but we will continue to have regular town halls. And information about upcoming town halls will be shared on the hub and through the Daily Dispatch. As always, I encourage those who have not yet done so to get vaccinated as quickly as possible. I think this has become even more critical, if that's possible, as we see the rise and the spread of the Delta variant in Ontario. Also, please remember to self-report your vaccination status to Employees Health Services. I did it myself recently, and it's very easy to do. Finally, please take a few minutes to complete the Employee Wellbeing During Times of COVID-19 survey. It's kind of a mouthful, that title, but a link to the survey is available on the hub and in the dispatch. This will really help us to tailor our efforts to help people with their coping and with their recovery from all of the stress and strain of the past 18 months. As always, thanks everyone for your ongoing efforts to meet the needs of our patients. I'm very grateful for that. And I will now turn it back to Lucas to lead us through the balance of today's agenda. Lucas, over to you. You're doing a great job.
Thank you very much, Rob. One of the things I guess really important before we get to our next speaker is just doing a bit of housekeeping, reminding folks who are probably used to this by now, but using the Q&A function to ask your questions as speakers go through. We'll do our best to answer. Of course, as Rob pointed out in the agenda, we will have an instance of Q&A also available, so we'll try to address some of those themes. And then later on, as we get to celebrations, if we could add those into the chat when called upon. And so with that housekeeping out of the way, I'd like to hand it over to Sharon Pearson, EVP Clinical Operations and Chief Operating Officer. Sharon.
Great, thank you, Lucas, and good morning, everyone. I'd like to provide a brief operational update on how we're doing this week and 2 weeks since our last update. As Rob had indicated, our operations are starting to return to normal. During COVID, our emergency department volumes dropped by anywhere between 20 to 30%, depending on the site. We're now seeing those volumes start to return to pre-pandemic numbers, and I'm sure the ED staff could attest to that. Our ALC volumes are also increasing as a result of COVID in the long-term care homes. Their occupancy declined, as we all know from the media reports, and across the last several weeks, there's been efforts to increase the long-term care home capacity closer to pre-COVID. So HHS, along with other hospitals, saw a lot of transfers, discharges happening, but that new capacity has been maximized. So what we're seeing is our volumes start to increase. So in the last few weeks, we've seen close to a 30% increase in our ALC rate. We continue to work with our partners to expedite discharges, as well as, of course, we have a satellite health facility, which is a wonderful asset available to St. Joe's and HHS to support our volumes. So we continue to work to maximize occupancy at the SHF site. The other activity that we are seeing that I wanted to highlight is around our labor and delivering. We've seen a very significant increase over year with our deliveries. And you can see on the slide there a 14% increase when we compare our activity to last year. And we had a record month in June, excuse me, with 367 deliveries. There's lots of work underway with Bruce's team and the obstetrical team to maximize space and capacity to accommodate these additional volumes that we're seeing. Not sure of the source of the volumes. We do know that there's pretty significant migration into Hamilton, given our real estate market, and lots of young families moving in. So that could be in part, and it could also be in part to some trends around COVID. And on to the next slide. Rob mentioned certainly seeing some stabilization in our COVID numbers, and those numbers are declining. We still have some COVID in the ICU. There are 12 COVID or COVID-related critical illnesses right now in the 2 ICU adult sites. Ward patients, there's only 2. We still maintain our ECMO program with a current 6 patients. So, you know, as Rob said, we're not out of the woods yet, and we still do have some critically ill patients and continue to receive critically ill patients on a daily basis. As part of the census balancing process that happened throughout wave 3, we did receive a number of out-of-region patients. We have 6 remaining in our facility, and we'll continue to work with our partner hospitals to repatriate those patients. 1, when the patients are ready, and 2, when the facility is able to accept. If we go to the next slide. In terms of the staff deployment, number of staff have returned, as we reported a few weeks ago, which is wonderful. So close to 260 have gone back to their home units, and there's plans in place over the course of the week to get schedules changed so 20 more staff can return. There will be 17 staff that will remain deployed to support the clinical areas, and we'll work with those staff to find dates that they will return to their specific units. Planning's underway for the urgent care center to reopen, along with the return of the obstetrical program to West Lincoln, which is currently on redirect to Niagara Health Services. Our surgical procedures, we continue to work for a return to our pre-COVID volumes. The last report was we are at 82% of our surgical activity and 74% of our procedural activity. Through the province, there is a plan to have an application process for submissions to have innovative projects to support surgical ramp-up activity. So HHS is participating in that planning with Les Gauthier and Dr. Stephen Kelly, and we do have proposals to move forward with from HHS, along with proposals in partnership with Ontario West. And next slide. The assessment center, which we have had up and running since the very beginning of wave 1, will be closing as of July 15th, as will the other urgent care based assessment center operated by St. Joe's in the East End. And there'll be one remaining assessment center left in the city at Mohawk College. And there'll be more communication out to staff in terms of how to access testing on an ongoing basis. And then finally, the mobile health unit, as we've reported through the hub and here at the town hall, we are decommissioning. We will have that completed hopefully in September. And the good news is folks will have their parking back in September too. So that's it for the operational update, Lucas, and happy to take questions in the Q&A.
Thank you, Sharon. Appreciate it. Next up is Dr. Dominic Mertz, Medical Director in Infection Prevention and Control. And as Aaron would always say, Dominic, what's going on with everything COVID?
Thanks, Lucas. Yeah, going back 2 weeks, given that we are now presenting every couple of weeks here, this was the picture as per June 22nd, and you will see on the next slide that for most provinces, their rates per 100,000 per week have pretty much decreased by roughly 50%, not that much in Ontario, but still case numbers going down. The only region that's currently struggling is obviously Yukon, which you see there with around 200 per 100,000 per week, keeping in mind that given the small population, you're looking at 15 to 20 cases per day, but nevertheless, it means that they see very high rates at this point of time. Next slide. Now, obviously, Quebec came down very quickly, I would say, despite the success, well, not that much success yesterday, but a lot of success by the HABs. Alberta in particular, we will see over the next few weeks how their pretty much full reopening will be affecting those numbers, which are currently in the range of where we are sitting at in Ontario. Ontario, however, on the next slide, at least some improvements as well. We can get haircuts, and that included myself finally after many, many months. Next slide. That's the provincial view of our case numbers. Black line where I expect us to be sitting by the end of the week, slightly lower again than in the last week, and very similar to where we've been end of June last year. So very, very similar ballpark as when we started summer last year. Next slide. Hospital admission wise, the upper black line showing you total numbers admitted, again, similar to where the province was sitting at in July 2020. In terms of ICU, and you probably could guess from what Sharon presented today, the vast majority of patients currently admitted are in the ICU and not on the ward. And as such, our ICU number of ICU patients is more similar to where we've been in November 2020 and still significantly higher than last summer. Next slide. That's the modeling from May 20th. And as you can see, we continue to do much better than what has been predicted. And these were predictions without Delta back then. And then on the next slide, the more updated, but not recent anymore modeling from roughly a month ago. And again, here, Delta was being taken into account. And again, we are doing much, much better with currently roughly 50% of what had been predicted with the best case scenario. And adding to that, the other positive piece here would be that we are vaccinating at a higher rate than the 180,000 per day that was estimated there. We are typically above 200,000, which will help us to reach a higher immunity in the population quicker than we would have expected a month ago. Next slide. That's the ICU predictions or modeling from 1 month ago. And you can see this one, in contrast to the case numbers, is very much on point. We continue to follow those lines quite well, sitting currently at just above 200 cases with COVID or labeled as COVID, I would say, being in our ICUs at this point of time. Next slide. The bad news is, yes, Delta is not only here, it's at least estimated to be responsible for more than 80% of our cases at this point, plus the RT, so the effective reproduction number for Delta is around 1, which means that the Delta cases are stable or slowly increasing, while the Alpha cases continue to plummet. So the reason for the decline we've seen over the last weeks is Alpha more disappearing, while Delta is taking over. And with this in mind, with additional reopening, we will at some point start to see Delta picking up and case numbers to increase again. We will come back to that. Next slide. The Hamilton view here, we are similar to June last year, I would say. So we have higher case numbers than we would have had in July last year. But again, very similar ballpark, and certainly much, much lower at this point than we've been between the second and the third wave. Next slide. Hospital picture here, that's the entire city and not just HHS, again, comparable to end of June last year with significant higher ICU admissions, which is more comparable to what we have had during peak of wave 1, but less than half of what we had, certainly at, well, much less than just half, probably a third or a quarter of what we had at peak during wave 3. Next slide. That's our community case numbers. So taking out the close contacts, the outbreaks, we continue to sit at those around 5 per 100,000 per week. So deep in low epi, which has implications on our policies, as you should all know by now. Next slide. The 2 regions or public health units in Ontario that are currently not considered low epi and from which we would test patients more aggressively, for example, pre-procedural, are Grace Bruce Health Unit and region of Waterloo. While the region of Waterloo is coming down in terms of case numbers, they are also struggling in terms of hospital capacity at this point of time. And for now, they remain in that non-low epi bucket, and we will be testing patients who need procedures and are coming from Waterloo because we would consider them as non-low epi. Next slide. I tried to, and that's to some extent a little bit arbitrary, to add sort of end of wave 1 versus beginning of wave 2, and then even more challenging between wave 2 and 3 to settle on a date where sort of the handover from wave 2 to wave 3 happened. But I wanted to give you an idea here again how COVID affected us over the last 3 waves. And you can see that from 1,000 cases roughly to 9,000 cases in wave 2 to more than 11,000 in wave 3 and counting. We would still consider those as being sort of post wave 3. But when you're looking at the death, as we predicted earlier this year, where we said that we will see a higher number of cases, but less death. Eventually, that's what happened, as you can see here. So we had only 45 deaths locally in wave 1, We had the max mostly among the elderly population in wave 2 with 234. So 2.6% was the infection fatality rate back then, or the case fatality rate, I have to say. And then in wave 3, it's 1.1% of known cases that were fatal, or 121 cases so far. Next slide. Trying to explain what happened, you cannot really compare wave 1 to wave 2 because we tested much more in wave 2 and would have missed much more cases in wave 1. So that certainly explains why, as to why the case fatality ratio came down from wave 1 to wave 2. But at the same time, we certainly had improvements in management, first and foremost the corticosteroids, but also other supportive care and treatments that we learned are helpful going through wave 2 and wave 3. Also, what's different in wave 3, as you know, that a much larger proportion of those cases were in the younger population, and as such, a population that's less likely to have severe outcomes. And then certainly by end of December, beginning of January, vaccines starting to kick in, and we will come back to the vaccine effect, which is probably the most important one when we think about post-wave 3. Next slide. So that's the Ontario data where they analyzed the effectiveness in the real-world experience based on Ontario data. Next slide. And I will try to quickly guide you through this quite busy table here. On the next slide, you see highlighted what I first want to chat about. That's symptomatic infection with the Pfizer vaccine. And you see from non-VOCs with 61% to Delta 56%, Alpha 66% effectiveness. That's very similar. You have wide confidence intervals around that. So that doesn't mean that it's any worse for Delta than for Alpha. That could be just a coincidence to some extent here. It might work a little bit less after one dose, which we mentioned previously. This is about symptomatic infection, as I mentioned. Once you have the 2 doses, you're sitting at around 90% and very wide confidence intervals here. So bottom line, they work. And when you go further on the next slide, you will see that for Moderna, the first dose may even be better with roughly 70% of the second dose, similar with 90%, AstraZeneca 65%. So again, very similar to the mRNA vaccines. We don't have data there for second dose because there's not enough people with 2 doses of AstraZeneca in the system to draw conclusions there. When we look at what we most importantly want to prevent, which is hospitalizations or death, on the next slide here, you would see higher numbers, right? So for Pfizer, 80% of the first dose, 95% of the second dose, Moderna, 85 and 95% respectively. AstraZeneca, 85% after 1 dose. Again, no data for the 2 doses there. So bottom line is vaccines are working very well against all the variants of concerns that we have, and they, as previously mentioned, they are best at preventing severe disease, but they are very good, excellent, I would say still, in preventing any type of symptomatic infection as well. Next slide. That's a summary by the province, and just first the definition of partially vaccinated and breakthrough and fully vaccinated. They use a cutoff of 7 days, so 7 or more days after the second vaccine, you're considered fully vaccinated. Before that, from like 14 days after the first dose, you're considered partially vaccinated until you're considered fully vaccinated. And the key findings there, and I will only focus on the last months, so May to June 2021, there were a total of close to 30,000 COVID cases reported. Of these cases, 83% were among not vaccinated people. Then you had 15.6% in partially vaccinated, and only 1.2% of 356 cases that occurred in fully vaccinated and are considered breakthrough cases. What's not mentioned on here, which again is very important for you to understand, many of those so-called breakthrough cases were asymptomatic individuals identified during outbreak investigations or after exposures, or typically mildly symptomatic. When we are looking at who's requiring ICU admission at this point of time for COVID, for the vast majority, those are not yet vaccinated individuals. So if you want to prevent a severe infection, the vaccines are the one thing that will prevent that from happening. Next slide. That's the reopening framework, as you know, with the estimated date of July 21st to go into reopening stage 3. We entered on June 30th, reopening stage 2. On the next slide, just highlighting again that from a vaccination perspective, it doesn't apply anymore because those 25% fully vaccinated, that would have happened 2 weeks ago already. We have an amazing pace in terms of how quickly we get people vaccinated. Next slide. That's the data as per July 5th, and I'm always behind because it changes so quickly every day, but just giving you a view of on top, Ontario, at the bottom, Hamilton specific. When you're looking at Ontario, we've been sitting at 78% of adults with a single dose, 47.8% fully vaccinated. Among 12 plus, it was 77% and 45.1% respectively. In Hamilton, we are a little lower, 4% lower in terms of first doses and 3% lower than in fully dosed or fully vaccinated individuals than the Ontario average. And I hope that we can catch up with that average and get more people vaccinated as soon as possible. Next slide. Now, the good news is once you update the data, and that came out last night, we actually crossed those more than 50% of adults now fully immunized within the province. So that's great news. We are getting close to 80% of adult Ontarians with at least one dose. And even in the 12 plus, we see a significant increase in people vaccinated. Next slide. That's how Hamilton compares to the other public health units. And again, you can see that we are in the lower tier here, but the difference are typically in the small percentage of difference between the public health units with the highest versus the lowest vaccination rates. Next slide. A very important piece when you think about harm from COVID is you want first and foremost the elderly population, those with comorbidities, fully vaccinated. And as you can see here, we have a very great success, I would say, in the 80 plus population with far more than 90% with a single dose, above 80% second dose. And this goes slowly down the younger the population gets. The 50 plus is the population that's most important to get fully vaccinated. And there's still work to do, obviously, but it's very reassuring to see that in the very elderly population that we are achieving very, very high vaccination rates. Next slide. That's how we compare to other countries. This is people of the total population. So here, not among adults or eligible population, of the entire population received at least one dose of the COVID-19 vaccine. You can see we continue to lead here just before the United Kingdom and Israel. And then we have US and some European countries following after that. Next slide. When you're looking at fully vaccinated, we still have some time to go to catch up with the UK, the United States, and eventually Israel. Doing a rough math on the next slide, you will see that it will take us roughly 1 week to get where the United Kingdom and United States are currently sitting at. They will probably continue to increase it as well. But we are close to catching up with them given our pace that we have. And in 2 to 3 weeks, we might actually be at the levels that Israel is has people vaccinated at this point of time. Next slide. Now, what does that mean and why is that important? Now, you're probably following what's happening in Israel, what's happening in the UK, what's happening in the US. And there's one common picture: Delta is spreading, and Delta is spreading among the unvaccinated first and foremost. What you can see here is number of cases per 100,000 per week. For Canada, purple; Israel, green; United Kingdom, blue; and US, yellow. And I just zoomed out that last part, and you can see that exponential growth that United Kingdom sees in terms of case numbers. You also see the green line, which is Israel, which at low numbers at this point also sees a significant increase, but the growth has declined. So we are carefully optimistic about the situation there. And as you know, as I just showed you, Israel has higher, in particular, fully vaccinated population rates than the United Kingdom would have. United States remains stable at this point, but what you would see is that in states that have higher vaccination rates, things are better, typically cases coming down still, while in states or counties that have low vaccination rates, you start to see increasing case numbers as well. And again, mostly driven by Delta. Next slide. That's Israel again, zooming into that last piece, because compared to the case numbers they would have seen during their first, second, and third wave, it's still very small numbers, right? And it looks like they may be plateauing, but it's too early to say here. But you can also see at the bottom, the green line, that's the reproductive number for number of deaths, that actually continues to decline despite the increase in case numbers, suggesting that thanks to the vaccine, yes, you may see so-called breakthrough infections of people who test positive, have been fully vaccinated, not even necessarily symptomatic at this point. Those add to the cases, but certainly not to the number of deaths. And as long as you have your highest risk population well vaccinated, it doesn't necessarily result in the same correlation that we have had with case numbers followed by hospital admissions and eventually by death. Next slide. Now the UK sees a much more significant increase. And again, I zoomed into that last piece there, which shows you in different colors, in the blue line being the hospital admissions and the green line being number of deaths. With number of deaths, they do see an increase in the meantime. It's still very small compared to what they would have previously seen. But number of hospital admissions, you now see with several weeks delay, a slow increase as well, not comparable to what they would have had in their second wave, but they certainly see an increase there as well now. Next slide. Another way to look at this, and this is logarithmic here, you see again in purple the case numbers, which are comparable to where they were sitting at in November 1st, so at the peak of their second wave or wave 2A. When you're looking at hospitalizations, they are more comparable to where they've been mid-September, and in terms of death, more comparable to where they've been in September. So you see a certain decoupling between case numbers, hospital admissions, and death by those proportions clearly shifting. So they see a much lower mortality rate at this point than they would have seen previously. Again, thanks to a large population that's at least single or double vaccinated, but you still have that large cluster or large population of unvaccinated where nothing has changed. And as you know, Delta may be even more severe than Alpha. So for those people, it's not good news having Delta spreading. Next slide. Now, my last slide is just a summary of the two philosophies that we certainly see globally among the two countries with the highest vaccination rates. On the one hand, you have Israel that reintroduced masking indoors and started to vaccinate teenagers in the light of the increasing case numbers that they've seen, trying to keep the case numbers sort of in check, assuming that this is A, achievable, and B, will prevent any potential harm among unvaccinated as well. While the UK relies more on that decoupling of case numbers from harm or severity, and is still planning to go ahead with a full reopening in July 19th, despite the significant increase that they see in terms of case numbers. And obviously, just having Canada in mind, there's a lot of room between those two. And again, we will only know in a few months how one or the other strategy will be working out. So still, again, lots to learn from COVID, many strong opinions out there. I think bottom line is there's a lot of uncertainties with different opinions, and we will keep learning how we can coexist with COVID in a post-vaccine era, I would say. But bottom line is, it's not too late to get your first dose. It's not too late to get your second dose. Just get vaccinated. That's our ticket out of this. Thank you very much. Back to you, Lucas.
Thank you, Dominic, for a very informative presentation. And this isn't a scientific fact, but I hope that the tears of those Montreal Canadiens fans after last night will help combat the transmission of those who celebrated after Game 4. Here's hoping, and we'll have to watch as time goes on. Next up to present is Michelle Leroux, VP Human Resources. Michelle, over to you.
Thank you. And I'll only take a moment. This is just a reminder further to the email communication that went out today. Dr. Frolick has done a great job at communicating with our PR team the importance of the employee wellness survey. And just a reminder to everybody that the deadline is July 12th, and the work that Dr. Frolick and others have done to bring this forward will help inform not only what we do as an organization, but strategies even within HR about supporting our people. So we encourage you to take the time, and our wonderful PR team even has the little link at the bottom of the page there, so you can just scan it on your iPhones. It's on the hub, and we hope you will take the time before July 12th. Okay, thank you.
Thank you very much, Michelle. Appreciate that. Next up, I believe we're handing it over to Barry. Barry is supporting the Odyssey work amongst the team. Barry, if I'm correct in my agenda, my topics of flow, I'll hand it over to you. And if it's wrong, pass it right back. Barry, over to you.
Thanks, Lucas. I think I am up. And hi again, everybody. Just a brief update about Odyssey. This slide will now be starting to be familiar to many of you. And I would just tell you this long and winding road that we're depicting here takes us to a proposed and a planned launch on June 4th, 2022, which is now 330 days away. And there's just an enormous amount of work going on in the organization. You'll see on the bottom right-hand corner here, the little purple section called Phase 2, which is where the project is right now. Lots and lots and lots of activity going towards building the HHS version of the EPIC Foundation, Canadian Foundation system. We'll be completing Phase 2 in very early August and then moving on from there. Next slide, please. Excuse me. So as I mentioned, we are just in about 3/4 of the way through Phase 2, and that will be coming to an end. There's lots of other activity outside of the work groups and the build phase going on, and that includes a current walkthrough to determine the best place for all of our new equipment and where that will be. We'll actually be beginning to deploy new devices throughout the organization in the early fall and extending through into January, and you'll see these new devices soon. There's a huge amount of work going on to validate our conversion from the Meditech world to EPIC and all of the documentation that needs to come over from Meditech to EPIC, and that work will begin in earnest in August. But what I'd really like to to highlight today is something that some of you may not yet be familiar with, which is a term called super users. The success of an Epic implementation obviously is based on a huge amount of work getting the system ready for HHS, but the most critical stage of the go live process is that we are training the 15,000 people at HHS who will be interacting with the Epic system in order to provide patient care. In order to do that and to train all of our staff, we have to provide you with outstanding training, and we're working very hard through Ashley's team to do that. And part of that involves identifying what we call super users, who are individuals who will be committed to becoming exceptionally familiar with the Epic system, facilitating the training piece, and then the absolutely critical phase of the go live, where we will be providing at the elbow support for everybody who is working in the system. So if they're concerned or there's an issue, that somebody's there to help them. So we're going to be starting to recruit folks who want to be identified as super users and will be an absolutely critical part of our go live and to taking us into the Epic world. So you're going to start to hear more about that, and I would encourage you to give that some consideration as we start to roll out the ask for individuals to consider to be a super user for us. Last slide, Luke. And so just one more time, don't feel shy for a second to contact us at Odyssey at hhs.ca, or you can follow me on Twitter or reach out to anybody who you know is involved in the project. Thanks, Lucas.
Great, thank you, Barry. Next, just a bit of a reminder, as Rob said at the outset, you know, there is an ability for us to self-report as employees to employee health of where we're at in our vaccination journey. It really helps in some of the planning and awareness as we go forward. So just, you know, a bit of a plug there using the QR code there and shared, you know, across the hub and other places to self-identify where possible. Appreciate your time. And it is rather easy, as Rob alluded to as well. Next thing that we'll go to is the Q&A, and you know, as often, lots of conversation happening in the chat function. Maybe where we'll go first, if we could hand it over to Bruce. Bruce, if you could touch a little bit around the recent change in walk-in appointments and a question in the Q&A specifically around Pfizer or other vaccines and walk-in process.
Thanks very much, Lucas, and my apologies. I meant to be typing an answer and I hit answer live, and so I forced myself on camera, which wasn't my preference, but it is good, folks. It's really effective today. Anyone in the Hamilton community over the age of 12 who would like a first dose of a COVID-19 vaccine can and are encouraged to walk in to any of the large-scale clinics. So that's the HHS clinic, the St. Joe's West 5th clinic, the First Ontario clinic, also the ArcelorMittal Dofasco vaccine clinic, as well as any of the Hamilton Public Health mobile clinics to receive a first dose. And all of those clinics will have Pfizer doses on hand for any youth, because that's the only type of vaccine that a youth can get, or mRNA vaccines, Pfizer or Moderna, for anyone else, and they are equally appropriate for all. So you can learn more about those clinic locations and their opening times, etc., on the hamilton.ca website at vaccine booking. So really want to encourage us to get that word out, that it's easier than ever to get that first dose of a vaccine.
Thank you, Bruce. Next one that we're looking at is Barry, maybe, you know, always a tough conversation, but capacity is one of those challenges, and definitely appreciate, I think, the importance of super users and how, you know, downstream that'll help in a more seamlessly way of incorporating the work. But how are we going to create capacity for folks to be super users during some very challenging times, obviously?
Yeah, Lucas and everybody, listen, we know that this is an enormous challenge for the organization, and you've probably heard me say before that HHS absolutely has to get to the electronic world and to get caught up with our peers and truly be on the cutting edge from a patient care point of view. And that means we need to have Epic. So we have to do this. We understand the challenge, and we'll do our very best to help with capacity. And I would say that although people will be signing on for this, it's not imminent that they're going to have to actually start that work. That the big work on the super users will be into the fall and especially into the sort of February to June timeframe. So I hope that we'll have a chance for stabilization before we start taxing folks. I know that's not a simple or an obviously easy answer, but that's how we're approaching this.
Appreciate it. Thank you very much, Barry. And maybe Dominic, maybe I could tap you on the shoulder. Some questions coming through around masking. One being around any potential bacterial risks of having a mask on. And then maybe if you could also speak to whether there's any conversations going on around the future of masking and plans as our vaccines continue to increase and other things continue to lax a bit, but maybe just any insight would be appreciated.
Yeah, I'm just looking at the question regarding bacterial infections. Nothing that we would be aware of. I mean, there's quite some concerns that had been raised by also some anti-masker groups about the potential negative effect of masking. Nothing really that would have worked out in a way that it would be a limiting factor per se. There's certainly people who develop sensitivities, etc., and we have a process, as people know, to support those people and to find alternative solution. And my understanding is that our employee health service has been very successful accommodating those people with different mask types, etc., etc. The other question would require a crystal ball at this point. I think what people are working towards, and that's something that needs to come from the ministries first and foremost, is that we may be able to reduce the use of eye protection. But again, at this point, our hands locally are bound in the sense that it's not our decision. The Ministry of Labour would intervene very quickly if we were to say, no, we no longer require eye protection in clinical settings, even in the absence of anyone who would require proper contact precautions. So at this point of time, no changes. The next change that I would foresee would be that we can relax some of the eye protection rules, and then we will go from there.
Great, thank you very much. And not seeing any other questions come up in our Q&A, maybe now is a good time to transition to our recognition portion of today's town hall and celebration. Obviously really important. Folks that have a celebration that they wish to write, they can write that in the chat. I think alternatively, you can option to be invited in to present live, but otherwise, please feel free to identify any of those now. And I guess, happy to get us going while some folks write and self-identify, but with the assessment center closing, as Sharon mentioned, and that being part of my portfolio that I was lucky enough to support over the last year, just really a recognition to all of the staff who stepped up and not only provided care in the assessment center, but oftentimes supported outreach across our LTC homes or in our adult and pediatric sites. So recognition to all of you, from the leadership to the staff to everybody. Thank you very much for your work. Sharon, I see you come off. Maybe you've got a celebration there.
I do. Thanks, Lucas. And I would echo your comments about the assessment center at the West End Clinic. That I think they were among the first groups to be involved with the COVID planning, and we had to rally that assessment center quickly amongst many unknowns. So thanks to that team and to Lucas for his leadership. I did want to call out actually the site administrators from all of our sites, and I'm really hoping I don't miss one. Brenda St. Amant from St. Peter's, Amy Williams from the General, Cindy McDonald, West Lincoln, Kelly Falzone from Children's, Kim Alvarado for the JCC, Liz Ferez, who's just replaced Jennifer Cotis at the Juravinsky, Donald LaForce for King West. These people through COVID, these individuals since wave one, I've been working diligently, day and night, many weekends, many evenings, really ensuring that the needs of the sites were taken care of, be it for staff, be it for patients, be it for the families. So I really just wanted to make sure that we extended a thanks to that group. And I'm just thinking as I'm talking, I miss Colleen Anderson from the Ron Joy. So anyways, many thanks to that group. They have done inordinate work through these waves of COVID for all of us, and deep appreciation to each of them.
Thank you, Sharon. And Kelly Campbell, I see you've come off. Do you have a recognition or celebration?
I do, Lucas. I just want to call out a few groups for the MHU. We had even less time to start planning to take it down than we had to put it up. So I just kudos to the team that responded, within literally 24 hours to start to pull supplies and equipment out of there. In particular, Jen Renuso from the Capital team, who worked very hard prior to leaving on vacation to get all of her work done. Annette Lasavita in terms of not only getting supplies and an amazing supply room set up in the MHU, but then stripping that all down very quickly and reallocating supplies, as well as our HITS colleagues, Paul Campanola in particular, that worked very hard on the network in terms of switches and access points and getting all of that set up. And the telecom group, Lori Monahan and Amy Jackson for all of their help, Edie Stewart for Rico, and just really great support from Corinne Tony, as well as the director. So I just want to thank everybody for coming together on such short notice, supporting me in that work to make sure we got our part done to facilitate getting the MHU decommissioned as quickly as we could and the parking lot returned for September.
Great. Thanks, Kelly. And Rob, I see you've come off, and there's also a recognition in the chat. So maybe I'll hand it over to you for that, and whether you've got a recognition celebration you'd like to make as well.
Yeah, I do. And Kelly Campbell might wish to supplement, but I just wanted to really thank everybody who helped in responding to the code gray at Mumsy the other night. We had honestly a situation that could have been really horrible that was averted when we lost our air conditioning at the site. And the team, the whole team came together and worked really hard to make sure that we were able to restore environmental services to the site. And people did extraordinary things very quickly in order to avoid that. So thanks to Kelly's facility team at Mumsy, but also everybody else who was involved in the response to that code gray.
Great, thank you very much. And I just see from Allison Fox Robichaud, I want to celebrate the ICU team at the General who continue to care for patients with COVID-related illness. Although it was better, we still have many younger patients who remain very ill. And thanks to all the staff who are redeployed and have now returned to their home units. I'm also seeing in the Q&A recognition from Anne Laughlin to, I'll try this, but Elizabeth Van de Sompel, a registered nurse who is retiring from the Breast Assessment Center after greater than 30 years of service. So thank you for your contribution, Elizabeth, much appreciated. Not seeing any other, there we go, from Nicole. Thanks to the DI and IR teams that support X-ray and CT for COVID volumes. So great recognition there as well. And Dave, obviously affirming, Rob, your recognition of the code gray. So shout out to all of those who helped that along. It's probably a good transition. Maybe with that, Rob, we could hand it back to you for some closing comments and get everybody else along on their day. Rob, back to you.
Yeah, thanks very much, Lucas. And my thanks go to all the presenters today who I thought did an excellent job in bringing us up to date on those very topical projects and other matters happening across HHS. Thanks to Lucas for standing in very capably for Aaron Level. And thanks everybody as always for joining us at the town hall today. We are going to slow down, but I think one of the silver linings out of COVID was the development of this modality of communication where we can on a regular basis in real time both present and respond to questions. So we'll definitely, this is one of the things we'll definitely keep going as we move forward. So Once again, if you haven't been vaccinated, please do so. I think it's, more important than ever that we get all of our workforce with 2 shots. We owe it to ourselves, to our coworkers, and most of all to our patients. So thanks all for being here today, and we'll see you again next time.